this, it's just a normal Zoom, but it's going to the Facebook group. And there we
Ooh.
are. I can see
Very
us.
good.
Hey, Bronnie, thanks for joining us.
It's a pleasure. It's weird.
I wanted to start with your background because I think a lot of people do know, but I reckon a lot of the new grads in my group might not know about your history, your degrees. Can you start there?
Yeah. So way back before the dark ages, in the early 1980s, I graduated as an occupational therapist. And then I pretty quickly moved into pain management because I was doing vocational rehab, which was not a thing in New Zealand at the time, and started to see most of the people I was seeing had pain. And then I left to move to Christchurch, did my master's in psychology, which I'd always wanted to be a psychologist, but my mother didn't want me to because I was going to probably blame my parents for everything. But, I could do that without help. So
yeah, you have the backing.
Yeah, exactly. And then I did that, and my research for my master's was looking at a return to work program for people who had graduated from the pain management 3-week program, but who wanted to go back to work. So I did that, and then I went on from there to do my PhD, looking at people who live well with pain. And I guess most of my career has been in pain management or prevention or early management or something to do with pain.
Yeah. And your experience with your persistent pain, did that come before or after you decided to help people in that?
It was before, but it's never been my driving reason for learning about pain. I actually got really fascinated with people doing work, and I'm nosy. I really like to look at people's jobs and how they do stuff. And so it was out of that, noticing that most of the people had pain as the major problem, that drew me into doing pain management. And my job down here was working for the Burwood Pain Management Service, where I was introducing the idea that returning to work is both normal and that people with pain want it. They just want it done right. So my own experience was as a new grad OT, doing a little tango in the doorway with a large man who was on a gutter frame, and I landed underneath him and hurt my back. It was as simple as that. Yeah. And I got Mackenzie was really fashionable at the time.
Yeah.
And we did traction, and we did interferential, and we did ultrasound, and we did all sorts of things, and nothing changed. And my GP at the time sent me into the Auckland Regional Pain Service, which I didn't know anything about. And I went to see Dr. Michael Butler, who is a godsend. He was one of the first members of IASP, so the International Association for the Study of Pain. Went to study with Pat Wall, who did the Melzack and Wall gait control theory, and he gave me the words that nobody with pain ever wants to hear. He said, I'm sorry, but there's nothing that we can offer you. And I was gutted. I really was just gobsmacked. You can't do this to me. And he told me I had to read the book, The Challenge of Pain by Melzack and Wall. It was a little paperback, published by Penguin, and I've still got a copy of it. I know, got to treasure these things. And that was like Explain Pain back in the 80s.
Yeah.
Basically, it said, you've got this nervous system, it gets its knickers in a twist, and you get this experience of pain, but it's not related to tissue damage. Which was like, oh my God, I'm not harming myself. It's fine. I'm okay. What that didn't do was teach me how to get back to doing normal stuff. Okay. That was another book by Connie Peck, who's a psychologist, a behaviourist, and she talked about doing a behavioural approach. So that was walking for 10 minutes and walking back for 10 minutes and giving myself a gold star, and doing that for a week before I changed it. And gradually, through time managed increasing my activity level. And that did the trick.
You could be like the unbiased holy grail of pain science, having done health professional psychology and experienced what you've experienced.
It's a difficult position to be in, but it's quite common actually. We like to pretend as health professionals that it's not, but every conference I've been to and I've asked, put your hands up if you've had pain that lasts for 3 months or longer. And at least a third, usually about a half of the audience will say, yeah, that's me. But if you ask them, do you have chronic pain? And it's like, no, not me. I don't have chronic. But actually, they fit the definition. And the distinction is important, I think, because clinicians don't want to identify with those people with pain, because they like to, as humans, we don't like to be seen as the same as the people that we're trying to help. We like to separate our tribes. And as soon as we recognize that the person sitting in front of us is actually just the same as us, then we've got a problem. So I think we tend to, as health professionals, believe that we are somewhat different. And of course, we wouldn't get into this much bother as that person. And actually we do.
Like, if you have the knowledge about it, you can prevent it, as it's almost like a ridiculous notion.
Yeah, well, it's like the idea that if you explain to somebody about pain, then that should actually fix their pain. I know a shit ton of pain science. I've been studying it for a long time. I live with daily pain. I've got fibromyalgia. It's not going anywhere. So don't ever expect an explanation to take somebody's pain away. But also don't expect to have the pain go away as the end result, because that might not happen. In fact, for lots of people, a huge number of people, that's just not the case. We know if you've got fibromyalgia, you're not going to have that go away. If you've got osteoarthritis, that's going to hang around. We know that if you've got diabetic neuropathy, that's probably going to hang around. Lots of low back pain doesn't disappear. And yet we have this weird idea that we could prevent it from turning into long-term disability or long-term pain. But what we don't remember is that it's not the pain that's the problem. It's the pain getting in the way of what people want to do, and their distress about their pain. That's the problem. So
when you first heard that, Bronnie, when you first heard what Dr. Butler said to you, were you actually... Sorry, what was that?
I was gutted. Absolutely.
I was going to say, were you actually relieved, or were you gutted for a while and then you felt some relief?
I remember going home and just howling. I was just so upset. And then I started to read the book. And it was like, and he did it in a beautiful way. And I'm internally grateful that I got referred to him and not to an orthopedic surgeon or to somebody else who would, put needles into me or whatever. Because at that time, it was all about steroid injections into the epidural steroid. And that would fix pain. And so I'm really grateful that he didn't do that. I'm also grateful that he didn't put me on medications. What he did say to me is that, we know that lots of people there's nothing really that takes the pain away. We don't have a good medication for this. And so I've never really relied on meds. And I've never found anything either. Because since then, and this is something I found out in my PhD as well, you don't stop being okay with trying something as an experiment to see if it's going to change your pain. It's just that you'd be a bit more discerning as you get on with living with pain, and that if it's going to get in the way of my lifestyle, then you can forget it. So no, I'm not going to wear coloured tape on my back just because somebody says it might be wonderful, or a crystal, unless it happens to be a little, glittery diamond one that fits on my finger. Don't mind that. But, it's not going to take the pain away.
Yeah. And I was asking you offline, which triggered this chat, and I've been asking other health professionals as well. How do we approach that person? So this is going to our Facebook group, a lot of new grad physios. Someone comes in, let's say they've had pain for longer than 3 months. And then does the new grad go into this like, let's have a good conversation, let's have a good interview, let's figure out what's happening here for this person. Is there a moment in time where you should have that conversation that you had, or is there a moment in time where you don't have that conversation and maybe it was the right movement, the right type of optimism, the right type of goal setting actually does get them out of pain? How do we ever know that moment? How did you receive that moment for yourself?
So I'm guided by a few things. We know there are some diagnoses that are unlikely to resolve. So if you've got osteoarthritis, if you've got fibromyalgia, it's just not going to bugger off. It's just going to hang around. So you can be really quite upfront. And while I was gutted by being told myself, this is not going away, what I didn't get offered at that time, probably because it wasn't available, was the opportunity to do some learning about how I could live with pain. And today that would be done differently, but at the time that's what happened. But now I think, looking at what the qualitative research says, basically people with pain don't want to be fudged. They don't want to be misled or on this false sense, maybe it could all disappear and life will go back to the way it was. In fact, people get a bit pissed off with that. We didn't used to tell people they had cancer. Now we do, because people don't like that sense of being misled. So the way that I propose doing it, because we don't know what combination of bits and pieces are going to help somebody, or whether this is going to help that person not have pain or not, we can be really honest, say, look, I don't know what's going to happen over the next 6 months. What I do know is that right now you've got lots of pain. So I wonder what we can do to help you live your life as well as you can. Live what matters to you at this moment, so that you're moving towards a life that's worthwhile living, irrespective of whether you've got pain or not. Because if pain goes away, yay, this person's already on their road towards, living a great life. And if it doesn't, they're living their life. And that's really where and it's their life, by the way, not my idea of what their life ought to look like. We can talk about that too. But we're being straight up. We're also saying, I'm going to accompany you as you figure stuff out. I don't have all the answers, but I'm here to help. I've got a few clues, but what can I do to help you experiment with stuff? And then we can cheer people on as they're having a go. And we can also learn to be a bit humble as they step back and say, hey, that didn't work. And it might work for the next person, but it didn't work for this person. So it puts us in a different position. We're not the experts proclaiming on high. We become partners and buddies and coaches and much more collaborative. And I really like that. It's a lot more fun. And it absolves me of having to be the expert and perfect. And, we come out of school thinking we've done all the best training, we know all the tricks. And it only takes probably about 6 months of that to realise, damn, these patients don't follow the rules. And then we can get quite disillusioned. This stuff isn't working. Why not? What do I do now? And that sets that merry-go-round of finding another course. I'm going to do a course of this, and then I'm going to do a course of that, and I'm going to be the most amazingly trained person. Only just to discover after a few years of doing that they don't work either. And eventually we come around to calling ourselves eclectic, which basically means I have no clue. I'm just using what I remember. But I think we could move away from that eclectic thing into saying, actually, I'm just going to accompany you. We're going to be partners. We're going to help you work out some stuff, figure out some stuff based on what the research tells us, what my experience clinically tells us, and what's important to you. That's the guts of evidence-based practice. But, we learn to follow the rules in school because otherwise we won't pass.
Yeah. There's a lot there. Philosophically, I wanted to go right back to, you were talking about cancer patients in some cultures. I think it still happens. I think if the patient is quite elderly, like let's say 85 plus, and they've been given a diagnosis, they don't tell the patient that this is what you have, as if telling them would be nocibic and end their life sooner, versus, no, I'm just going to, go on. You're saying that you have found some research that it's the opposite. People just want to know.
Yeah, people really hate being lied to or misled. And even when we think about cancer, people with cancer, the move towards the informed consent has meant that medical practitioners really have to think hard. Is it worth undermining trust with this person to deceive them and not disclose that something nasty is going on? And certainly in New Zealand, you wouldn't find people not being told, unless they're, beginning to lose their memory and maybe have dementia. But even then, they'll try to make it clear that you're coming to the end of your life. And I think we think we're being kind, but what we're doing is actually holding that person, making that person wait. They put their life on hold until something works. And there's this desire to be like they used to be, even if it was 15 years ago that they played rugby. When I get better, I'm going to go back and play rugby. Well, you were 15 years younger when you played. You can't be that person again. So I think we owe it to people to be honest, compassionate. This is hard to hear. I know that. I still remember that day, and I don't want to know how many years ago, a long time ago, when I heard that, those words, there's nothing we can do for you. There's nothing medical that will help. But that sets a line under this sort of search for the single answer, and starts people to say, well, if this is as good as it gets, then I might as well make the most of what I've got. And it might take a bit of time for the person to feel, it's not acceptance, I hate that word, but it's a willingness to say, if this is reality, then what else can I put into my life? And everybody's response is going to be different. Some people will really hate that, and you'll get yelled at, and you'll get people who are angry. I had one father ring me and a doctor up to say, you've consigned my daughter to a life of suffering and misery, because she had a chronic pain problem. But actually, we weren't doing anything. We were just saying, actually, you've done all the medical stuff that works, and there's nothing more that we can offer you. That's not saying you're going to always be on the scrap heap. It's just acknowledging, if you put your energy into solving that problem and put everything else in life on hold, then what are you actually going to return to? We call that dead man's goals, because even dead men don't feel pain. I want to be a live person, and I want to live a life that's full of things that matter in the presence of pain. Still there.
Every time you talk, Bronnie, I have 3 or 4 more tangents I want to go and explore.
I warned you.
Thank you for doing that. If I'm going to go back to the group, and it's private practice, young physios in Australia. I guess the question that I get a lot privately is, Adam Meekins walks into your clinic after he's hurt his back, and So,
Yeah, Adam.
so how do you, you know, how do you know or treat differently, and do you treat differently? This is an acute back pain. I think at this point, there's, a really good chance that pain will go away and we'll focus on your function and we'll build you up and we'll talk about your goals. What happens next? It's hanging around a bit longer. Are you starting to get an inkling? Is there any difference in approach at that acute level that maybe defends against a persistent level? Do we have any of those links? I try to ask one question at a time, but that was about 6.
Yeah, that's okay.
Mm.
Well, so Adam's pain, it's been around for what, 2 weeks now?
Yeah.
Roughly? That's pretty normal. I wouldn't see that as a terrible thing. I think that's pretty common. Up to 6 weeks is thought to be a reasonable amount of time that we wouldn't be worried if somebody's pain was still hanging around. In fact, we wouldn't be worried. I wouldn't be worried because, I don't care about pain. I actually don't care about pain. I never ask about it after we've established on that first session just what pain's like.
Yeah.
I'm much more inclined to talk about doing, but then I'm an OT and that's what we do. I don't think there is much of a difference, to be honest, but I know that if we ask somebody about their pain every single session, we're going to hear about their pain.
Yeah.
And that means they're going to be attending to their pain and noticing and monitoring their pain. Is that what we want?
No.
We can be empathic and say, looks like you've had a really tough week because you told me about your pain. Hey, it's great you came in. Now we can do some stuff that might help. Most of the guidelines for low back pain say really simple stuff like self-management, exactly what Adam's doing. Let's eliminate the risk of anything nasty. So that was done. That's pretty straightforward too. We know what to look for. And then we start to do stuff that's about getting back to function. That's, and simple self-help stuff. That's what self-management's about. So it might be for Adam, it's been, having a hot bath. For other people, it's Wim Hof ice baths. Not for me. I like my warmth, thank you. But it could be anything. Like, it might be different positions. I know Adam's been lying on his back with his legs out at night to sleep. These are simple things. They're not evidence-based. So if you go to the guidelines, they don't tell you these simple self-help strategies. They say exercise is really good, but we don't actually know what kind. That's okay. We can figure that one out. And don't do a whole lot of stuff because that doesn't help either. And eliminate the really nasty. That's essentially what the guidelines say for low back pain. So movement is good. Just do as much as you can, as often as you can without overdoing it. And maybe do some simple, practical problem solving. Bring your OTs in because that's our job. How do you put your shoes on, do your laces up? How do you manage your work? How do you drive your car? If you've got a sore neck, how do you look back to reverse your car down the driveway? These are simple things that guidelines don't tell us about, but are actually the things that people really want help with. We kind of forget that in this mad dash to give somebody some kind of, jazzy, jazz hands type pain thing that's supposed to fix it. I haven't found any way to manipulate a disc bulge. I've never found anything in the literature that says that it helps. Lots of things about learning to relax bits and pieces and strengthen other bits and pieces, but why would you need to do that when backs just get sore and cranky for often no particular reason, or a whole host of different reasons that we can't put our finger on? So let's just focus on doing normal stuff.
And then if we go back to again, a new grad private practice in Australia, they're likely to have Adam come in and likely to do some manual therapy and likely to probably do the movement and give some guidelines around movement and ask those questions. And they're also likely to see that person again. Where do you stand on that? And not where do you stand, how do you make those decisions, whether this is someone who could do with some manual therapy, or this is someone who is pretty independent and maybe I'll just give them my email and I might not see them again? How do you kind of explore those decisions?
So going back to the NICE guidelines, which are the ones I've read most recently, so they're uppermost in my head, they're saying do manual therapy, but only in the context of a bigger program of people who are making very slow progress.
Mm.
And I think the things that probably matter the most are when people are freaking out, aka catastrophizing, freaking out. And, Adam acknowledged that even he was thinking the worst at times. But what he wasn't doing, and this is what I look for, is people who avoid moving.
Mm.
So if you're not moving, you're avoiding all these movements that hurt, then I get alerted to it's probably not a good thing. And let's help you move with a bit more confidence and perhaps a little bit more relaxation. And that's the way I would triage. I don't touch people. These hands do not touch people. I am an OT. We don't do that.
Yeah.
I would guide somebody though to move, and I have done this. We'll guide somebody to do some movements. Let's explore picking this thing up from the floor or from the chair, and let's look at ways that you can do it that might feel better. What happens if you breathe out when you bend down? What happens when you breathe in? What happens if you lean a little bit? Let's just shift your weight around on the balls of your feet and then onto your heels. And that's it's movement experimentation. That's cool stuff. And that is, OTs do that too. It's not exercise, so we're allowed. Actually, we can do exercise because for some people, exercise is a meaningful activity or occupation. I don't find it that way, but lots of people do. So an OT would be quite entitled to say, hey, I'll get you back to the gym. I'd rather get somebody onto their kayak if that's what they were doing before and not the gym. And I'd like to get somebody climbing trees if that's what they did before, or pushing the pram around, or doing their grocery shopping, or driving their car. But that's the way that I would do it. So coming back to the guidelines, NICE says if you are pretty straightforward, self-management's a good thing, and do some nice normal movements. That's lovely. Off you go. And a bit of pain relief, but be careful because NSAIDs are not that great on your gut, and you've got some cardiovascular risk. Paracetamol's not worth it. Probably not gabapentin or pregabalin or any of your opioids. Maybe a bit of codeine if your NSAIDs aren't helping. That's pretty straightforward. They don't talk about acupuncture, manual therapy, hot baths, cold baths, or interferential or ultrasound or anything like that. They just say some pretty basic stuff once you eliminate the nasties. And so then you triage if somebody's not moving, and especially if they're saying, I'm really freaking out and I'm really worried about X, Y, and Z. And by the way, I'm not sleeping and I'm just not doing much. Then you probably start to ramp the multi-professional approach. I prefer interprofessional, but where you might bring on board your OT and maybe a psychologist, and you'd probably want to see a doctor to maybe do some prescribing, but you pick your doctors. But that's the time when you might do a bit of manual therapy. Some people really like hands-on. I don't think there's any problem with that. If they say, hey, I really like some hands-on, I don't think that's a problem. But it's got to be accompanied by other stuff. And it's not going to work miracles. Usually it gives you a little window of maybe an hour or two, maybe a little bit longer of comfort, which gives you a chance to do some movements. That's what it's for. It's like, why do we take pain relief? Oh, that's right, so I can move more. I used to have long conversations with patients about not wanting to take meds because it would mask their symptoms. I don't know if that still happens, but it used to be a real big thing.
You still hear that? Yeah.
Yeah, it's going to mask my symptoms. I'm going to do myself some damage. Well, actually, the reason for pain relief is so that you can move.
Yeah.
So do it. So I think, as a physio, new grad, I'd be looking for those warning signs. This person's really down in the dumps or really pissed off. They're not sleeping. They're really worrying about what's going on, freaking out more like, and they're just not moving. Then I'd be thinking, hey, this person probably needs some more encouragement and a bit of gentle compassion for them, and let's get some other people on board to give them a hand.
And Bronnie, just so we can wrap up, because we will talk for hours and we're both in lockdown, so we've got nothing better to do.
Exactly.
What would what would your advice or guidance or tips be for a new grad physio who potentially there is a shift? I seem to be more optimistic than anyone in these circles, but I think private practice in Australia is going the right way. But there's still a lot of new grads where it is a little bit formulaic, and we're going to do these techniques and we're going to rebook you this amount of times. What's your advice for a new grad exploring this, that Adam Meekins type of patient? What conversations do we have? What tips, advice, and maybe even questions do you ask in your consults to help?
I think start with your recipe, because that's what you learned, and it's quite scary to go off piste. No, you want to stick with what you know, but be really willing to listen to what this person is saying. First of all, what's their main concern? What are they actually worried about? It might be that they think that it's cancer or they're going to end up in a wheelchair. Well, give them some nice, encouraging information. It's usual for low back pain to hang around for a bit, grumbles away, and then it'll gradually fade away for most people, as long as you keep moving. It's kind of nice. I would say check in with their reaction or their response to each step of your algorithm. So if you said we need to do this movement because that's what the algorithm says, check out if it did what it was supposed to do. If it didn't, you might need to change tack and go a little bit off piste. But at least you've got that framework there. And always go from what you're doing in clinic, thinking about how is this person going to actually use this in their daily life? Because if they do it only with you and they never bother doing it ever again, which, sad to say, happens, then what's the point? And if they do it with you, but they erratically do it at home, or it's irrelevant to the movements that they need to do at home, then you're wasting your time. So don't waste people's time, but listen to what they have to say about what matters. If they really want to start driving again, or if they want to go, water skiing, well, don't ever put somebody's goals down as being, it's far too advanced, you'll never do that. Let's work out on our way towards that. What do you need to do? How are you going to do that? And let's start building on that, because the worst thing that you can say to somebody, one of the worst things, is that you can't do that ever again. And I've heard, I had a plumber chat with complex regional pain syndrome who was told he'd become a master plumber, and he worked on our arts centre, which has big, he worked on the lead piping and bits and pieces and copper and stuff like that. So he's really skilled. And some case manager told him that because he had complex regional pain syndrome, he needed to give up his job. He spent 20 years building it up. Needless to say, we didn't listen to that particular piece of advice, and he went back to work doing his normal job.
Yeah.
But, for somebody to cut somebody off at the knees and say, you can't do that because I don't think you should, that's pretty rude. Never doubt the tenacity of somebody who really wants to do something. They'll do it.
Do you have questions in your interview that evoke that type of conversation that will help you have a consult like that?
Because I don't do the physio subjective objective ever, I might ask, one way is to go around the 24-hour day, take me through your day. Or I might use the fact approach, which is tell me about your work, tell me about your relationships, tell me about your health, tell me about fun, and how is this problem getting in the way of all of those? Because that starts us on to thinking about what matters to this person. And that's a gentle way of doing it rather than tell me your goals.
Yeah.
Because, you know, who sets goals? Only health professionals, and they never do them for themselves. You know, so let's just talk about what's this getting in the way of? How can I help you get back there? Because that's, people are just wanting to be who they used to be. And even if they can't be the same as they were, at least they're doing the things that matter to them, the values that infuse their life. And that's the bit that we want to try and preserve for people, that they can still do things with the qualities that they really want, even if it's in a different form.
Yeah. Thank you, Bronnie. Thank you so much. We chatted on the Physio Network podcast, and I wanted to go a bit slower, and I had all these selfish questions that I wanted to ask you. So thank you for indulging me.
Now we've hit Gareth hopping all around them, but that's normal for me.
Yeah, no, I loved it all. I'm gonna hit pause on the Facebook Live, but if anyone has questions for either of us, we'll circle back to them.
Absolutely.
All right.